Today I'll be presenting a case of a 68-year-old man with metastatic EGFR mutant positive non-small cell lung cancer. The patient initially presented with recent onset shortness of breath and unintentional weight loss. He didn't have any nausea, vomiting, other neurologic symptoms. His past medical history was relatively unremarkable. Hyperlipidemia that was controlled on a statin. He had been a former smoker but quit 10 years ago, and he had a 30-pack-year history of smoking. And physical exam was notable only for decreased breath sounds, most notably in the left lower lung field on auscultation. In terms of his clinical workup, his labs were unremarkable. Pulmonary function was moderately reduced with an FEV1 over FVC of 55%, and the DLCO was 65% expected. Chest X-ray showed a left lower lobe mass, and on the CT, it confirmed the presence of a 3.3 centimeter pulmonary mass involving the left main bronchus and ipsilateral subcarinal lymph node. In addition, the CT showed adrenal metastases, and the CT core needle biopsy revealed lung adenocarcinoma. MRI of the brain was negative. I think every patient with non-squamous histology, and in fact, I think every patient with non-small cell lung cancer in general, should get molecular profiling. And in this case, this patient had an exon 19 deletion, and ALK, ROS1, BRAF were all negative. PD-L1 testing showed a TPS of 20%. The other typical mutation being an exon 21 point mutation, the L858R alteration. And if you have either of those typical mutations, an exon 19 deletion or an L858R point mutation, then treatments for typical EGFR mutations would be indicated. And so at the end of the day, this was a stage 4 non-small cell lung cancer. In terms of his treatment, he was started on erlotinib at 150 milligrams daily and ramucirumab at 10 milligrams per kg IV every 2 weeks. After 3 months, imaging showed a partial response with the decreased size of the lung metastases and the adrenal metastasis. And imaging at 6, 12, and 18 months showed continued stable disease.